So welcome to our web-based seminar, Strategies and Approaches for Video-Based Directly Observed Therapy. My name is Eileen Napolitano, and I am the Deputy Director at the Rutgers Global Tuberculosis Institute. I will be moderating today's discussion. I'd like to just let all of you know that the Global Tuberculosis Institute is on social media, so you may like us on Facebook and follow us on Twitter for the latest updates and resources. So let's start with a question. Are you currently using video DOT in your practice? Okay, great. So nearly half of a third of the respondents, the participants on the webinar, are already using video DOT, and 20%, nearly 20%, are planning on it in the future. So we hope today's program will provide you with some valuable insights and information on continuing or initiating a video DOT program in your area. Our faculty for today's program are Dr. Richard S. Garfein, a professor with the University of Southern California, San Diego, Department of Medicine, School of Medicine in San Diego, California; Teresa Casey, a nurse program manager at the Barren River District Health Department in Bowling Green, Kentucky; Christine Chuck, the Director of Field Services at the New York City Department of Health and Mental Hygiene in Long Island City, New York; Daryl Glashauer, a communicable disease epidemiologist at Clark County Public Health in Vancouver, Washington; Carolyn Lyons, a TB coordinator at the Barren River District Health Department in Bowling Green, Kentucky; Josh Van Otterloo, an applied epidemiology fellow at Clark County Public Health in Vancouver, Washington; and Patty Woods, a public health nurse consultant with the New Jersey Department of Health in Trenton, New Jersey. Before we get started, we have two more questions we'd like to ask. First, what systems do you use primarily for video DOT? So 60% of the participants are not using any system right now, and the other 40% are using a variety of different systems. So hopefully you will glean some useful information from the presentations to follow. And the second question is, for those who do have systems, what apps do you use for video DOT? So Skype seems to be the app that is used most frequently. And we'll hear again during the course of the presentations about a number of different apps that various programs are using. Our first presenter today is Dr. Richard Garfein. Dr. Garfein is a professor at the University of California, San Diego, Department of Medicine, Division of Global Public Health. He has 22 years of experience as an infectious disease epidemiologist, designing and implementing observational and interventional research studies. He is a member of the Global Consortium for Drug-Resistant TB Diagnostics, which conducts international research on molecular diagnostics of drug-resistant TB, and leads the site for CDC's TB Epidemiology Studies Consortium. The results of his research have been published in over 124 peer-reviewed articles. Beginning in 2010, he has been working with county health departments to create a mobile solution to the high cost and staff burden for conducting TB directly observed therapy. I will now turn the program over to him.
Well, thank you. Welcome, everybody. I've been tasked with giving an introduction to using mobile technology for conducting directly observed therapy remotely, and I'll give a little bit of information about the research that we're doing as well, and I hope this will be a useful introduction to the topic preceding the next presenters. The purpose of monitoring TB medication adherence is to document whether or not medication doses were taken and to encourage treatment completion by the patients. The goal is to reduce TB mortality and morbidity, to prevent TB transmission to others, and to prevent the acquisition of drug-resistant TB. The cost of tuberculosis around the world is significant, and as you can see, places like the United States spend over $5,000 per patient to provide them with first-line drug treatment, and the cost of that goes up considerably when the patients are infected with drug-resistant strains. And just as a comparison, in San Diego County, where we have fewer than 300 cases a year, we spend over $8 million just to treat tuberculosis. This slide just shows that first-line TB treatment consists of 4 drugs that are taken daily over a 6-month period, and that when we consider the global burden of TB, we're talking about 2 billion doses of medication, which results in 11 billion pills being taken. So the pill burden for TB treatment around the world is considerable. The good news is that 90% of the cases can be cured with first-line antibiotics, but adherence is critical. And the contributors to poor adherence are things like the long treatment regimen, being 6 months or more, the occurrence of side effects due to the medications, and contradictions with other medications and alcohol could impact a person's ability to take their medication. But the problem is that poor adherence can result in drug-resistant strains of TB forming. And as we all know, second-line drugs are much more toxic and less effective than first-line drugs, so treatment becomes more difficult. It also drastically increases the treatment time and cost. And these drug-resistant strains are transmittable, creating a much bigger public health problem. And as we can see from this slide, as of 2012, there's been almost 500,000 multi-drug resistant TB cases reported around the world, and 43,000 XDR TB cases. And all these countries that are shown in magenta have reported at least one case of XDR TB. So the problem is real and it's growing. So how do we prevent this? Well, directly observed therapy has been promulgated by health agencies around the world and has been adopted by health departments as a method of trying to increase the rates of completion of treatment and decrease the likelihood of developing drug-resistant TB. And this can be done in multiple ways, but typically it's conducted by a health worker visiting the patient in their home or workplace or other place that's convenient for the patient. Or it could be conducted in a health center where the patient is obligated to show up at the health department at that clinic on a daily basis. The reason that DOT is recommended is because it improves adherence, it reduces the risk of acquired drug resistance and treatment failure and relapse of TB. It also permits intermittent dosing because if the doses can be ensured to be taken on schedule, then it's okay for the doses to be spread out a little bit further. It also ultimately can reduce the number of doses that a patient would have to take during the course of treatment, decreasing the likelihood of drug toxicity problems. But as we all know, there's limitations to directly observed therapy, which include the cost to administer it, the human resources that are necessary to implement, transportation that's required by either the patient or the provider to meet and observe the patient taking their medication. It could also be impractical or even impossible for patients that live too far away from health centers. It requires a lot of coordination between the patient and the provider, and as well as restricting the patient's mobility. Patients that are on DOT might be prevented from being able to travel either for work or for pleasure. And it could also create a situation where the patients are feeling stigmatized or their privacy is being compromised, and oftentimes patients report feeling patronized for having to go through this process. Over time, researchers have been developing new technologies to try to figure out better ways to do this. And I will classify these as in terms of indirect monitoring technology and direct monitoring technology. And for indirect methods, these include pill caps that have the electronic pill caps that can indicate when the pill bottle was opened. The more sophisticated ones now will also track the date and time that the pill bottle was opened and then send that information remotely to wirelessly to the health department so that they can keep track of when the patients are taking their medications. This technology has also been attached to blister packs And more simply, it could be attached to pill boxes or pill bottles that can include not only recording measures, but also reminder systems to help the patient to remember to take their medications. So all these systems are passive, and the problem with them is that they only tell you whether or not the patient actually removed the pill from the bottle, but it doesn't say anything about whether or not the patient actually swallowed the pill. So there are some limitations, although these methods have been used in clinical trials for TB as well as other diseases, particularly HIV. But the next level or the next tier of monitoring technology comes in terms of what I call direct monitoring. And these are systems by which the patient can be tested to find out if they've actually ingested the pills. And so these can include using blood, hair, urine, or toenail clippings to indicate to look at the level of medication that's in the patient's system. Some researchers at MIT came up with a fairly clever urine dipstick device whereby if the patient took their medication, then the test strip would light up, but rather than it just being a positive negative, it actually will have a series of numbers on the test strip that will become visible if the patient actually took their medication. And then the numbers can be sent via computer or mobile phone to the health department as proof that the patient actually took their medications as planned. And more recently, a company called Proteus has developed a microchip that can be attached to a pill or put into a capsule along with the pill. And the patient wears a patch on their abdomen, and as the microchip passes through the intestines and passes by the patch, it triggers the patch, and it indicates that the pill has been swallowed, and then that data is transmitted wirelessly to a mobile phone and ultimately to the researcher or the health department at the other end. This technology is FDA approved at the present time, but it's still going through a lot of clinical trials to actually look at its efficacy, and it's not available widely yet. And there could be some problems with patients being reluctant to wear a patch or to swallow a microchip. And then there's other smart technology like the smart pill. So these are all good methods. The problem with the metabolic tests are that they're difficult to determine whether or not when exactly the patient took their medication, if they're taking them on the appropriate schedule. And the other more expensive technology like Proteus is still a ways off and might not be acceptable to patients. So that sort of brings us back to Video Dot. Because it is more practical and because the technology is available more broadly. And so what I want to do is talk a bit about what Video Dot is and how it can be used. One method of Video Dot involves using a landline-based phone that includes a camera, much like Skype, except that rather than going through the internet and computers, it's going through hardwire telephone lines. And there was a study that was conducted in Washington, and I know that there's been some more recent data that's come from this, but from the published data, the study was conducted in 1998 to 2000 with one of these phones, and 6 patients were followed for up to 6 months, and through that they found 95% adherence among the patients on this Video Dot. And they also importantly found that the patients found this a very satisfactory way to conduct DOT. They found it easy to use, and most importantly, it saved the health department $18,000 per patient in staff time and miles. And so if you imagine a health department like Los Angeles with over 600 patients a year, that could be quite a big savings. In addition, San Diego has also used the same sort of a device, and in 2004 they did an evaluation involving 33 patients who were followed over a 9-month period. And again, they found a very high level of patient acceptance using this technology. And in that case, it saved over 27,000 miles of travel, which at that time was about $10,000. And it saved almost a half of an FTE of a health department employee. So significant savings in terms of manpower and mileage. But there are still some disadvantages to this technology. One is that it's still limited to business hours. The patient can only take their medications when the DOT workers are available at the health department to call them up. The patient must be at their home because this technology is not mobile. It has to be done in the patient's home. And fewer patients have landline phones these days. More of them are switching to mobile phones. And for places like San Diego, where a lot of our patients do travel back and forth across the border with Mexico, many of them live in San Diego part of the time, or Tijuana part of the time. This type of DOT would be impossible. We've heard that many health departments now, and I think we heard 19% of the people on this call said that they're using Skype as a way of getting away from the landline-based phones and switching to computers or mobile devices to be able to conduct the same sort of face-to-face interaction. And so there's a lot of technology out there. There's Tango, there's Uvo, there's Skype, FaceTime. Fuse is another product out there. And these are all being explored. They all have the same potential to be able to have this two-way interaction that's live. But there are some concerns about HIPAA compliance and security and confidentiality. As well as there's still some problems with technology in terms of connectivity and what do you do if the patient can't get connected. This brings us to the technology that we've been working on at UCSD, and I'll end with this part and as an example of another way that this can be done. In this case, we're using recorded videos as opposed to live. And one of the reasons for using a recorded video as opposed to a live interaction really stemmed from this issue of what do you do if the patient is ready to take their medication and they happen to be in the center of a large office building and they have no cellular signal, or maybe they're they live in a neighborhood that has terrible connectivity. So that was part of it, and then we realized that by recording the video, it also has the advantage of allowing the patient to take their medication any time of the day or night, and they don't have to have somebody else available to do that. And so what we did was we developed a simple application for the mobile phone, which allows the patient to turn on and off the video recorder with a couple keystrokes. And then when the patient is ready to take their medications, they prepare all their medications, they have their water ready to go, and they start the video recording. They can see themselves on the screen, sort of like a mirror. They hold up each pill, say what the pill is, place the pill in their mouth, drink their water, swallow it, then hold up the next pill, say what it is, and they go through the process with each pill individually. This kind of helps to make sure that the patients are actually swallowing the pills and not holding them in their cheek, because it's hard to do all that talking while you're cheeking pills. And then when they're finished, they press the stop button on the recorder, and the videos are automatically encrypted and sent securely to a secure server where the DOT worker from the health department can log into a secure website and observe the videos and document what they saw. And so if the patient does this correctly and the video shows up, the process takes about a minute or two for the patient and a couple of minutes for the DOT worker on the other end to observe it. If the videos don't show up, or the videos are of poor quality and the DOT worker can't verify what was taking place, then the DOT worker would contact the patient and troubleshoot to find out what happened and make sure that the next day that the videos do come in correctly. So it's not an all or nothing process. It's something that still involves DOT workers and some interaction with patients, but at a much lower burden for both. So we did this study in a small pilot in San Diego and in Tijuana, Mexico, with 41 patients in San Diego and 9 patients in Tijuana. And we were looking to see, how patients would respond to this. And what we found was that the majority of the patients in both countries said that the the DOT process was more confidential than the in-person DOT process. They also said that they hardly ever failed to send a video because they were concerned that somebody was watching them. So again, they felt more secure doing this process. And we asked the patients after they had completed their DOT using Video Dot if they would prefer to do, if they had to redo their treatment, would they use Video Dot or in person? And all but one patient actually said that they would either had no preference or they preferred Video Dot. And that one patient who preferred in-person Dot was somebody who basically had a very chaotic lifestyle with a few kids at home and said, frankly, for her it was easier to have somebody come every day to her house and remind her when to take her pills, but it didn't have anything to do with the technology. And then we also asked if they would recommend Video Dot for other TB patients, and there was a resounding yes. And then what we thought was interesting was that as a result of using Video Dot, many patients actually found that they were more comfortable using smartphones. So by actually applying Video Dot in this case, it provided an opportunity to condition patients to getting used to mHealth. And so it could actually open up the door to more mHealth applications for things like diabetes, which is another common condition among patients with active TB. So, and I don't have it on the slide, but I'll just tell you that in this pilot, 95% of the patients from Tijuana, 95% of the doses that we expected to observe in San Diego were actually observed with Video Dot, and 96% of the expected doses were observed from the patients in Tijuana. So we had a very, very high adherence rate with very few missed observations using Video Dot. How does this compare in terms of cost? And what we did was we looked at the cost of providing Video Dot, which would include the cost of salaries for somebody to watch the video, transportation for dropping off and picking up phones, the phones itself, the phone charges. The only thing that we didn't include in that analysis was the cost for the Video Dot application and the use of the Video Dot application. And we compared that to in-person Dot costs, which included the staff salaries and transportation. And what we found was a considerable savings. So in San Diego, the average cost for a patient on in-person DOT is about $4,200. In Tijuana, it's about $460. And with Video Dot, it was approximately a third the cost of in-person Dot in both cities. And so this, even if we did include some cost for the use of the application itself, which ultimately would have to be added, it would we still believe that Video Dot would cost less than in-person DOT. And from the slide, we can just see that smartphone penetration in the United States now has exceeded regular feature phones, and that's just going to continue. So the availability of smartphones is going up in the United States. And I think what's also important to realize with use of technology for DOT is that once we have these devices in the hands of patients, we have the opportunity to do more than just watch people take their medication, but potentially to improve adherence, to increase their likelihood of actually taking their medication. And this is already being developed with other diseases. And it could include things like enhanced text message reminders or motivator systems. The patient will now have a phone in their hand that they could use to contact their provider if they need, if they have questions or concerns. We can also potentially push videos out to patients that could provide them with education or motivation to take their medications on schedule, and potentially link this information to personal health records. So this is just the beginning, but there's a lot of opportunity for mHealth technology, starting with something like Video Dot. So some future considerations that I want to make sure everybody's thinking of are making sure that we're always keeping the data secure and that these systems are HIPAA compliant, that we take into consideration both the cost to the patient and to the providers, as well as the cost savings, and that the form of technologies are acceptable to the patient as well as the providers, that we're thinking about the best mix of approaches for the populations being served. It might not be that every patient in a health department should get Video Dot. It could be a combination of VDOT plus in-person DOT plus other methods. And then we need to come up with best practices for the use of these technologies. And then finally, we need to think about policy issues related to whether or not insurance or Medicaid would reimburse for the use of these technologies, and to measure the long-term outcomes. And with that, I thank you for your time, and I'll turn it back over to Eileen.
Great. Thank you, Richard. That was really an excellent presentation. Provided us with a good overview, and then great to see some data about the use of video DOT and acceptability and, I guess, efficiency and effectiveness. Before moving on to the next section, we'd like to ask another polling question. What are some of the challenges you anticipate for using video DOT? Okay, so it's shaping up that people's major concerns are around technical issues and issues of confidentiality, privacy, IT and reimbursement are all somewhat on an even par. So next we are going to hear from several different healthcare workers from Kentucky, New Jersey, New York, and Washington. They will share their experiences and challenges of implementing video DOT. First, we will hear from Teresa Casey of Barren River District Health Department in Bowling Green, Kentucky. Teresa?
Okay, the Barren River District Health Department, we first implemented, we call it iDOT when we started it, Internet DOT. So we implemented that in 2011. We had a client who had a business in Brazil, and she figured out if she had to add on treatment to the end of her time, every time she had to go visit in Brazil, that she would never finish treatment. So she came up with the idea, and we have very innovative and forward-thinking administration here, so they gave us consent to trial this out, and we first completed the iDOT, did some practice runs at this person's home, she on her laptop. And so when she went to Brazil for her 2 weeks, we were able to successfully complete the DOT. So that was a major accomplishment and opened a big door for us with the iDOT program. Barren River District Health Department, we developed a protocol to prevent the client from pocketing or palming the medications. So during our Internet DOT, they have to have their hands and the medication in the visual field at all times. And we actually do an oral cavity check at the end of the DOT. And generally what we would do is we would have them take their medicine first, do the oral check, and then ask our questions to them, because it's hard to talk when you have a mouthful of medications. The systems that we used was Logitech, but unfortunately Logitech is no longer available, so we plan on using Skype and FaceTime for our future DOTs. Some challenges that we've come across are the reliability of the client. So our protocol includes that our client must take at least 3 weeks of face-to-face DOT and must be 90% compliant in order to be a candidate for the Internet DOT. There can also be language barrier challenges. Fortunately, our foreign population that speak a different language have been within the county that we are stationed in, so we have not used the iDOT with them. I would like to say that we cover 8 counties, and those counties are spread over basically about 3,246 square miles. So that can be a lot of traveling for our nurses and our outreach workers. So in some of those rural areas, they do not even have Internet access, so there can be a lack of technology or a lack of Internet access itself. If they have the computer but don't have the camera to do the IDOT with, we will loan them a webcam. They do sign an agreement that says that if that webcam is damaged or not returned, that they will be billed for that webcam. Other issues are also that clients may not have the ability to use the technology. We have our outreach worker go to their home at least 3 times while we are attempting the IDOT. The first time she will download the program and hook up the webcam for them. We'll go through the IDOT. By the 3rd visit, the client is trying it independently, and the outreach worker is there just simply to troubleshoot if there's any issues. Some of the technical glitches that we see, sometimes there's a storm or the client's computer is not working correctly. So we give them 2 options that they can either self-administer, or the local health department will have emergency packs and the client can drive over there and that local health department can observe them taking that medication and it will count. At any time, if the client does not follow our protocol, does not keep the pills in their hands in our visual field at all times, then that dose of medicine is not counted toward their treatment. So when all else fails, we always can revert back to DOT, and we had a similar situation in which we had a client who completed the initial phase well, but when we went to the IDOT, they become very unreliable. So their choice was to revert back to the face-to-face DOT at their home. They said that was the best way for them to be compliant with our treatment. So that is our experience and our challenges thus far at Barren River District Health Department. Thank you.
Thank you, Teresa. Very interesting. So next we have Daryl Glashower from Clark County in Washington, who will share their experience.
So it's a pleasure being on this call. Before I get started, I want to give a little bit of background about Clark County so that if there are other public health entities on this call, I want to make sure that they have an idea of the population that we serve so they can draw their conclusions kind of based on our population. So we are a local health jurisdiction. We're responsible for about 435,000 people. Our county has a nice mix of rural and urban areas, and our urban areas are largely an extension of the Portland metro area. And if you have any questions about where Clark County is, there's a small picture in the bottom right-hand corner of the slide indicating that Clark County is in southwestern Washington state. So I'm going to talk a little bit about our experience with EDOT. So that's a little point of jargon. Rather than IDOT, we refer to it as EDOT. We've used electronic or EDOT since 2009, and our first experience was actually a suggestion by a patient, and my colleague Josh will talk about that in a moment. In the past, we've used a variety of programs, UVU being the program that we used initially, and we have now moved into Skype. And we've also used a variety of types of EDOT, real-time and recorded. Initially, we used mostly recorded because it had the option of a person or a patient taking their medications at a time that was convenient for them, and it also had a timestamp on that. Since our early phases, we have now moved to mostly real-time using Skype. So we started slowly, and now this is our preferred method over in-person DOT, and we decide to enroll patients in EDOT on a case-by-case basis. Initially, we didn't have any real criteria for eligibility, and initially it was mostly based on patient interest. But since then, we've moved on to a more formal eligibility criteria which I'm going to talk about on this slide here. So this is kind of where we're at right now with eligibility. It's mostly patients who are willing and able to participate. So by willing, we mean patients who are invested, and that's kind of subjective judgment, but it's something that we take into account, and also their ability to use the technology. So we take into account a person's technological abilities before we consider them for enrollment in our EDOT. Another criterion is that they're not MDR tuberculosis. They have to have completed their initial phase of treatment, and there cannot be any medication intolerance or adherence concerns. But ultimately, the decision is made by our TB team, and our TB team gets together once a week to have a case review, and that includes our public health nurse, TB case managers, as well as our health officer. So the decisions to enroll someone into our EDOT program are not made in a vacuum, but made with the input of many people, and we draw on a large fund of knowledge. But we do have criteria for when we stop, and especially if there's adherence concerns, any medication intolerance, or if the patient decides that they no longer want to use EDOT. So if their preference is for in-person DOT, we make sure that they have that option. So some of the challenges that we've experienced are included here. First is our IT department. I'm sure there are many folks on this call that can actually relate to some of the conflicts that we have with our IT departments. Here in Clark County, Skype is a program that's discouraged by our IT department. Not necessarily because it's some sort of sinister software, but mostly we try to prevent employee abuse. And so to overcome that, it took kind of pushing the issue up to our department directors, both in IT and here at Public Health, for further deliberation. Another issue and challenge is reimbursement. So Medicaid and Medicare do not reimburse for electronic directly observed therapy, which limits our ability to recoup our costs. And finally, confidentiality and HIPAA are high concerns for us. There are a number of interpretations for the security rule, and where we're at right now is when we consider using recorded versus real-time, we've moved away from using recorded Skype and only using real-time. And we try to use software that meets our security criteria and also is commercially available and ideally cost-effective. So we do know that Skype is encrypted to HIPAA standards, and therefore we are moving forward using Skype real-time as our primary EDOT method. And lastly, this is how we've overcome some of our challenges. Our EDOT program has been more of a grassroots effort, starting with our staff who are actually having contact with our TB patients. So it's been a bottom-up effort, and there's also been advocating by patients. And so that takes into account that leadership buy-in is very important in trying to implement a program such as EDOT. And in the future, if we were to try to recoup some of our costs using EDOT, that would take a legislative fix if we want to recoup reimbursement. But we do save a lot of money doing electronic EDOT, so even though we're not reimbursed, the cost savings are considerable. And then we do a number of things to mitigate any potential liability due to confidentiality or HIPAA breaches. Those include informed consent, and DOT is the only thing that we do over the internet. We only use real-time, and we continue to search for fully HIPAA-compliant software that's reasonably priced, and we are always working to mitigate our liability. So that wraps up my portion of the presentation. Thank you.
Okay. Thank you, Daryl. That was really very interesting and particularly interesting to see your eligibility criteria as well as how you overcame some of your challenges. Next, we'll hear from Patty Woods with the New Jersey Department of Health TB program.
I'm going to tell you about New Jersey's experiences. Initially, we started in 2006 with an analog video phone. At that time, we developed some policies and procedures that addressed who would be eligible, which candidates would be eligible for the video DOT, how to maintain confidentiality, what we would do with non-compliant patients, and we also had the patients sign a compliance agreement so they understood exactly what we were doing with the video phone. And around 2013, we updated those policies to incorporate some of the new technology because around 2011, some of our counties started incorporating different remote forms of DOT because technology had advanced and our older technology had become a little antiquated because, as I said before, the analog video phones you required a landline. Not a lot of people have that, or they don't have the analog phone. It's digital. So at present time, we have about 7 out of our 21 counties have implemented this into their clinics. And I actually had a few more requests that 3 more clinics are interested in implementing it since I've made these slides. To date, in the past year, we've had about 30 patients that were placed on video DOT, and that yields about a 93% compliance rate, and only 2 patients had to go back to face-to-face DOT. Overall, the clinic felt that the DOT experience was successful, and it reduced field time, and it increased patients' compliance. In New Jersey, you may or may not know, in the last few years we've had some significant weather problems. We went through Hurricane Sandy, and apparently this winter we were in some type of polar vortex, so we had a lot of snow days that we weren't used to. So some of these patients that were on video DOT were able to get their video DOT when others couldn't get out. Clinics have used it while patients were on vacation, and they've used it while patients were even on vacation abroad. We've used it on people that went back to China for a while and back to India. The systems that we used was the analog video phone, which really don't use that often now because it has become obsolete. We use Skype. Skype can be downloaded on the PC or a smartphone, but with Skype, if you're going to download it on a PC, we had to make sure that they had a camera. There's FaceTime, which is pretty easy to use if both parties have the iPhone or iPad. You basically just dial it and then it'll connect. And then we have Tango and Uvu, which are applications that we use when the field worker and the patient have 2 different types of phones. If one has an Android or one has an iPhone and you can't do the FaceTime, Tango is another option. The one thing I like with Tango that we use, and I will speak about this later when I go over my case study, is it does give you the option also to send a video if you can't connect. Some of the challenges that we faced are access to Wi-Fi and connectivity. The clinic and the patient have to have Wi-Fi or some type of package, 3G, 4G, or some way to connect if they're using like a smartphone. We've had problems with patients being inconsistent with their DOT times, and those were the ones that had to go back to face-to-face as per our criteria of our policy and procedures. They were missing too many DOT times, and some of the clients, because of the patient's work schedule, they would do it pre-hours or post-hours, and they were not staying within the time frame. One of the problems we have is securing the equipment for the clinics and or the patients that don't have this equipment. So we do have some smartphones or track phones that the state has that we can lend out to these clinics that have somebody that's in need of going on the video DOT. We've had counties that have issues with the computers because they're blocked on their PCs at work and they can't download some of the applications. We've had 2 counties that wanted to use Skype, and they actually worked with their IT department to get that unblocked so they could download it and use the video DOT. Some of the pros that we did find, though, was people had decreased missed doses and increased compliance. We've actually had people that, because they know that they're doing this dose by dose, that wanted to actually do it on days that we may have been off or closed, and just worker was able to do that and we can accommodate them, that would decrease the amount of time they were on it. Or if we used an application like Tango and they sent the video, we would count that as a DOT. It accommodates the patient's work schedule for the times that, they couldn't get there before or after. And actually, people did feel that there was more confidentiality in this aspect because normally if we couldn't do it before or after their work hours, we would try to go to see them at their work site. So this was a much better option for a lot of people. And it decreased their staff time, and it also was effective with not only time to travel, but gas and the wear and tear on the vehicles.
Thank you. Thank you, Patty. That was an excellent presentation. Thanks for sharing your experiences in New Jersey. And finally, we will hear from Christine Chuck at the New York City Department of Health and Mental Hygiene, and she will share their experiences in New York City.
Yes, good afternoon. New York is a big city hybrid Department of Health, and by hybrid I mean we provide direct medical care to patients as well as conduct public health work. Over 70% of our patients are on DOT either in one of our CHEST centers or in the community. This is New York's second attempt at implementing video DOT as a supplement to face-to-face. Video DOT was first implemented in New York in 2005, but similar to, I think Richard mentioned, due to the change in technology, our attempt at video DOT was short-lived because due to the switch from analog technology to digital and the increased use of smartphone in the community. So fast forward to 2013, we find ourselves in the unique position of offering two forms of video DOT, live streaming video DOT, in which patients ingest medication remotely using a smartphone pre-programmed with video conferencing software FOOF, while the DOT observer observes the patient ingesting medication remotely using a webcam equipped computer. And the second option is recorded video in which the patient records themselves ingesting medication while the observer reviews the video at a later point. Video DOT is offered to eligible patients receiving treatment for suspected or confirmed TB disease. Patients are ineligible for DOT if they are hospitalized, incarcerated, receiving injectable anti-TB treatment, or residing in a nursing home. All patients must sign a DOT agreement and a responsibility for the phone. Upon enrollment, patients are loaned a smartphone phone programmed with Foosbox. Patients are assigned a unique conference number, and an observation schedule is set between the observer and the patient. Patient receives training from a public health advisor who goes out to the patient and meets the patient either at home or in a clinic, and the patient is shown how to use the phone. They're taught how to hold the medication in front of the camera and how to pour the medication so it's visible to the observer. Some of the challenges we encountered in setting up our video DOT program was securing the mobile phones with service plans for a patient. Luckily for us, we started talking to Dr. Garfman early in our planning phases, and we had several communications with him, and he was very instrumental in helping us to receive an in-kind donation of 25 smartphones with data plans through the Verizon Foundation and his study at the UCSD. A second challenge was identifying a video conferencing application acceptable to our IT department. Initially, when we first approached our IT department, we told them that we were interested in using Skype. And initially, right out the door, Skype was nixed, and the IT department recommended Tango as the software that we should use for our project. However, about 2 or 3 weeks before we before we went live, we were attempting to set up a dry run, and then at that point we were told that Tango was no longer approved for use on the IT server. So we, in talking to Richard again, we were offered the use of Skype, a Verizon endorsed product, which is HIPAA compliant. So we took that back to our IT department. It was reviewed, and finally it was approved for us to use FOOS as our application. FOOS in its initial form required 6 keystrokes to get into a conference, and that was, bulky for a patient. It's 6 steps before you could actually start to ingest your medication. So our IT department worked very closely with the programmers from FOOS, and we were able to get the keystrokes down to 1 keystroke now, which is much even easier than FaceTime because you need at least 2 for FaceTime. A second limitation was the FOOS only allowed 1 person to host a meeting at a time, and that was problematic in that if the primary observer was out, there was no allowances for a second person to host a meeting. So the patient would not be observed for that day. So that's something else that we had to work with the FOOS programmers to address. So we were successful in getting these keystrokes down to just 1 keystroke, and then the creation of a public and private meeting. And the public meeting allowed for multiple individuals to host the meeting. So we were able to have a primary observer and a backup observer in case the primary observer was out. So what new challenges that we're facing as we continue in our project is the excess use of data by our patients. As mentioned earlier, the phones are on loan with the service plans for our patients. We now are experiencing difficulties where we have patients using more than the 5 gigabytes of data that is assigned to each phone. We've had a patient use as much as 30 gigs of data. So this is a new challenge that we have to, going forward, figure out how we will be able to address that. Our preliminary findings suggest that video DOT is a promising alternative to face-to-face DOT. However, further evaluation of our project is needed to determine the benefits of video DOT on the current TB control efforts.
Thank you very much, Christine. Thanks for sharing the experiences of New York City. I think with respect to the implementations and challenges, a variety of different issues have been raised that will be helpful to those who are planning to use video DOT in the future. So we're going to move on to the case studies and outcomes and hear from the panel about their outcomes and case studies while using video DOT. So we're going to hear from Carolyn Lyons from the Barren River Health District. Carolyn?
Our case study is a 64-year-old male who had a history of pneumoconiosis in addition, of course, with the TB and uncontrolled diabetes. He received treatment for a year starting September 2011 and ending in August 2012. He lived in a rural area, little over 50 miles one way from our health department. Our staff time that we spent in doing a face-to-face visit was about 2.3 hours, and that, of course, is including the drive time, compared to an IDOT, which took approximately 10 minutes. Our initial phase and monthly screenings are done face-to-face, and with this particular patient, he completed 126 IDOTs, and, of course, that started after he converted in January of 2012. There was some delay in conversion due to absorption levels, but as you can see, it saved a lot of time that we would have had to have made the visit. Our outcomes, at being paid 42 cents a mile, we had a savings of $5,318.46, very significant for our health department. Our staff time savings on face-to-face DOT would have been, or was 289.8 hours versus 21 hours, and that was a total of 268.8 that we spent. And calculating down a little bit more on a week, work week of 37.5 hours, we saved 7.168 weeks of staff time that would have been paid out. So very significant. Our target time for doing an IDOT was decreased to a 30-minute period of time for the patient to be available and for us to be available to do the IDOT, compared to we have a 2-hour period doing face-to-face time, or face-to-face visits in the home.
Okay, thank you, Carolyn. Our next presenter is Josh Van Otterloo from Clark County in Washington. Josh?
My name is Josh Van Otterloo. I'm the CSCE Fellow with Clark County Public Health, and I wanted to sandwich my outcomes piece with 2 case studies that will hopefully show the direction we've gone with EDOT. So our first case study was our original EDOT patient. He's a foreign-born male in his 40s. He was an international preacher with spinal TB, and he never had any pulmonary involvement. He traveled regularly and used online video software to stay in touch with his family, his congregation overseas, and he also did online seminars with, this online video software. So given his long treatment, his frequent travel, inside the county, inside the state, and then also, all over the world, and, he was really comfortable with the software. He suggested electronic DOT. He suggested using Ubu, which was the software he used for all of his seminars and such. And we said, okay, let's give it a try. And it took a little while to get implemented, but in the end, we did electronic DOT for 9 months on this guy. He actually never did miss a dose. And by the end, we had recordings that he did in multiple states and in multiple countries. So this first case study was in 2009, and we had some more success with EDOTs. So we decided to look at our electronic DOTs as a group and do an evaluation. And so doing this evaluation, we had 4 goals. The first one was to characterize our population and, describe how people use electronic DOT. The second was to look at the effectiveness of DOT. The third was to look at the cost, and the fourth was to look at the overall program effects of EDOT. So first, we wanted to characterize our population. So from 2009 to 2013, we saw 52 TB cases. 12 of them did at least 1 dose through electronic DOT, because we started pretty slow on this, and so we've been ramping this up. In total, we had 1,016 electronic doses. Those who did electronic doses tended to be younger and male compared to those who did only in-person DOT. Cases used electronic DOT in a variety of ways. Some people did it for their entire continuation phase. Some did it only while they were traveling or on vacation. And then some did it, at their convenience. So they switched back and forth between in-person and electronic DOT. In these cases, generally, we just, we hoped that the patients would let us know whether they wanted their, next week's dose to be in-person or electronic. So moving on to effectiveness, we looked at a whole bunch of measures. We looked at treatment completion, missed doses, treatment interruptions, hospitalizations, and deaths. So, the big takeaway here was all of the people who did electronic doses completed treatment. And, partially due to, there only being 12 of them, there was no difference in interruptions, hospitalizations, or deaths. So our primary measure here was looking at missed doses and the rate of missed doses. And, fortunately for us, there was no difference in the likelihood of missing doses. So people missed doses at the same rate, whether it was in-person or electronic. one thing that was really compelling for us was looking at cost here. So what we did is we looked at the time spent observing DOT, the travel time for our staff, and of course the mileage. So in the time period 2009 to 2013, we saved over $28,000. When you split that by dose, that's $28 a dose, or $2,380 a patient. These savings let us kind of expand our latent TB treatment in the county. Before, we were doing mostly only latent treatment on contacts to active cases, but we've expanded that a little bit to look at other high-risk groups. And it let us begin a tablet computer loaner program. So this is, we would loan out a tablet computer to people who don't have a standard internet connection or don't have a smartphone or things like that, so we could capture that population as well. The next slide is about the overall program benefits. And I think the overall program benefits, the biggest thing, has been it decreases the burden on treatment for patients. The CDC ATS guidelines really stress, taking a patient-centered approach to treatment, and we believe that doing electronic DOT is one of these patient-centered approaches. The second thing was managing travel and inclement weather. I'm sure you guys know that's a challenge when someone decides they want to go somewhere for a week or go somewhere for a month or that sort of thing. And using electronic DOT, we could, record doses no matter where they were. And the second bit is no matter how inaccessible they are. There's some parts of the counties that are, really far away, and during winter weather, it's not safe for us to go and observe a DOT. So you can do it electronically. And the last bit is that it increased our staff flexibility. This is especially with the recorded doses, but also with the real-time doses, that we didn't have to spend as much time with each DOT, but also it was a more defined window. You didn't have all of these fudge factors around each DOT. All right, and so our last slide is our last case study that's kind of showing where we've gone. So our case is a foreign-born adoptee, age 2, with suspect pulmonary TB that we were treating empirically. She lived 45 minutes to an hour away in the mountains, and she was our first patient that we did using our tablet computer loaner program. Now, I'm sure as you know, DOT with small kids is more involved than with adults. In this instance, the case's mom would grind up the medication with a mortar and pestle, mix that with applesauce, and then feed the kid that way. So it was really about following the drugs. And that's harder to do with, a webcam or something like that. So we gave them a tablet, and these sort of challenges were overcome by a very motivated parent and a really cute kid. This kid got a gummy bear after they finished the applesauce, so she was super motivated to finish her applesauce, and she would give a long-distance high five over the tablet to our community health worker. And then just looking at that, time savings, 2.5 hours versus 10 minutes. That just seems like there aren't very many opportunities that are that good.
Thanks so much, Josh. That was really a great presentation. So we'll move next to Patty Woods, who will talk about her experience in New Jersey.
Thanks, Eileen. So this case study I wanted to talk to you about is a 58-year-old U.S.-born confirmed pulmonary case. He was treated with pulmonary TB 20 years ago. He's positive for HIV and on medication, had cirrhosis of the liver. He had a history of alcohol and drug use 20 years ago. He's an amputee and bedridden. And if you look at everything I just said, he does not meet our criteria of somebody that we would want to put on video DOT. So the reason I picked this case study is because if you look at all his situations, this is definitely going against our policy, but you also have to look at video DOT and the patients of what would fit best for each individual patient. So this person couldn't have face-to-face DOT every day because he lives with his wife. They have 2 dogs, one's a very big aggressive dog, and they have to be removed when a stranger comes in. Since he's bedridden, he can't get up to let anyone in, and we can't let ourselves in because we don't know if the dog is in or out. So that means someone has to be home, which wouldn't fit into his schedule or his wife's schedule, who has, activities during the day at different times. So we also, this patient also, because he's bedridden, needs to be transported to the clinic, which is very difficult because they have to pay for transportation. So a doctor sees him monthly in the home. So with this patient, we decided that some DOT was going to be better than no DOT because at least we'd have daily contact with all the problems that he was having. But we did compromise and come up with a solution of once a week, the nurse would come in and do a visual face-to-face DOT. So we can, have his wife available at least one day a week. We chose Tango because the patient already had it on his phone, and with Tango, some of the difficulties we have is with the connectivity, and with him, we don't know what time of day he's going to call because it really depends on the schedule or when someone's home to get his medication. So it could be anywhere from 1 to 4. And then with our schedules changing, we wouldn't know if we're always available where we would be at that time. So Tango was a really good option because he already knew how to use it, and in the cases that we can't get connected or in a case where we're not available, he can send the video. And after he sends the video, we'll always follow up with a phone call to make sure that, no side effects or anything that's going on. The other way that we use Tango or just some modern technology like smartphones was, besides video DOT, was since the patient doctor was going to the patient's home, at one visit we noticed he had a rash on his leg. We were able to video conference with the doctor, so she was able to talk to him, see the rash, take pictures until she got out to see him in the home. This has also worked for other patients that things come up on the weekends when the caseworkers aren't there. Another patient, again, had rash on the weekends. We'd come on Monday, Tuesday, it would be gone. So the daughter would take a picture and send the picture via the smartphone of the rash and kind of figure out what was going on that way. But with this patient, he has been 100% compliant with either video DOT or sending the video, and so far we have no adverse effects, even with all his medical problems. So the one thing I just thought that this case would bring home would be that it could be on a case-to-case basis, and you really have to evaluate what is best, but in this case we did go with putting it on even though it was against our guidelines, and it seems to be working out really well.
Thank you, Patty. I think that provided a great example of a way to resolve problems around complex and difficult patients. Our final presentation on case studies and outcomes will be again from Christine Chuck, New York City Department of Health and Mental Hygiene. Christine?
Yes. Our first case study is going to be highlighting, some of the features of the video conferencing software FoodSwap that we're using. And our first case is a 23-year-old college student with TB disease who started DOT in March of 2013 with good compliance. In September, the patient informed us that he would be going back to school and he needed an earlier DOT schedule, which the time slot he requested we did not have as he was on face-to-face. So the patient was enrolled on video DOT in September. And that worked well. So during one of his video DOT sessions, the patient reported that he had side effects to the TB medication, and he showed the observer a rash on his arm. With that, we were able to conference in a medical consultant, one of our DOHMH physicians, who did a physical, a virtual examination of the patient's rash and informed the patient, instructed the patient to take the medication, to continue with the medication, and the patient was reassured that the rash was not TB related. So on face-to-face DOT, the patient would be required to report to one of our chest centers for medical examination. So with face-to-face DOT using FOOT, the time was saved for the patient as well as clinic resources. And the patient would have been placed on self-administered therapy if video DOT was not available, as the requested time slot was not available. Patient completed treatment on video DOT. Okay, and our second case study is a 33-year-old male with pulmonary MDR TB, enrolled on video DOT, who traveled to California during his treatment. Avoiding video DOT gave us the opportunity to avoid involving the California Department of Health, as this process would require, sending paperwork back and forth to get the patient scheduled. By the time in some cases, by the time that would be finished, the paperwork was completed, the patient would be ready to return to New York, because the patient was there for just a few short weeks. So the patient had uninterrupted DOT while in California. We polled some of the DOT patients to find out what was their reasoning for accepting video DOT. And this slide shows the responses that we got from patients, and that it was accommodating. And I think one of the previous speakers spoke to the fact that our TB approach should be patient-centered. So in trying to address the patient's concern and making DOT more flexible and accommodating to their needs, I think speaks highly to that. So you can see here from the responses, patient chose video DOT because it was convenient method for observation. It preserved their privacy, and it was convenient for them, in their time convenient. And this is feedback from our 22 patients that we had enrolled in video DOT during the first 3 months of our DOT pilot, which was between September and December of last year. And that's it for me.
Excellent. Thanks, Christine. It's especially interesting to, again, see why patients are interested in accepting video DOT. So before we move on to our questions, a final polling question: what proportion of your health department's TB patients would likely be placed on video DOT if it were available? More than half of you would put somewhere between 50 to 100% of your patients on video DOT if it were available. So video DOT or eDOT, which I have to say I like that, is looks like it has potential certainly for expansion in the future. We've had a number of questions, a few questions that were somewhat similar. I'm going to synthesize some of them and ask them back to our presenters. So I wanted to start with a question for Richard, which was if you could elaborate on what the eligibility criteria were for your the selection of patients in Tijuana specifically.
So when we conducted that study, we used the same eligibility criteria in Tijuana and in San Diego, and because the technology was new and we were not totally confident in it yet, we specified that all the patients should be at least 18 years old. They should have uncomplicated pulmonary tuberculosis, so that meant no MDR, no secondary comorbid conditions that would complicate their treatment, no injectable meds, and that was about it. We didn't necessarily prevent people from being on it if they had a history of substance abuse or if they had, the only other restriction would be that they had to be able to use a phone. So if they were blind or couldn't manage a phone, that would be an exclusion. But in doing this study, we found that the technology did work and the nurses became more confident in it, and pretty soon they actually preferred to start putting their more difficult patients on it because it was the only way they could do DOT. So we heard lots of examples today of where the patients lived too far away or their schedule didn't work with the health department, and so we ended up with a lot more patients that would have been more complicated and otherwise not received in-person DOT because it was made it more feasible. So going forward in our new study, which we're doing in San Diego, San Francisco, and New York City with Christine, we have eliminated the restriction for uncomplicated TB. So now somebody with MDR, for example, would be eligible.
Thank you. The next question, I think, is the question came in for Clark County, and I think it had to do with a comment that was made regarding liability for video DOT, that there's more liability for a video DOT, and I wonder if you could elaborate on that a little.
Yeah, so this is Jarrell from Clark. So I thought there was a number of questions just regarding kind of in that same orbit of kind of the confidentiality and potential liability associated with Skype. And I just want to highlight that I think the consensus from this presentation is it's undeniable that there are significant savings in patient convenience to using eDOT. It's just finding the balance where you also preserve confidentiality. And although I can't give a full legal opinion, I can tell you what we're doing here. And it's this, is that per our evaluation, we understand that Skype is encrypted to HIPAA standards. And we know that there are HIPAA-compliant options out there, but we haven't found any that are cost-effective for our situation. So some of the things we do to preserve confidentiality, but also to mitigate any liability, is that we request patients use who are using our technology to sign an informed consent. And in that informed consent, there's language describing that we cannot guarantee that transmission will not be intercepted by unknown parties. And some of the strategies that we do use to protect confidentiality is that on the calls, we don't discuss diagnoses. Any Skype eDOTs, real-time eDOTs, are held in secure, locked office areas. The staff members who do the eDOT are already familiar with the patients through prior face-to-face meetings. We don't record, and these are voluntary. Patients always have the option to revert back to in-person DOT. And one last thing, as an aside, we mentioned we have a loaner tablet component to our program, and we use mobile iron software that allows us to remotely wipe a device in case of theft or loss. So we don't have any explicit objections from our county legal department regarding the use of real-time Skype. But regarding recorded Skype, our county legal department has weighed in that if we were to use recorded Skype, we would need, in addition to an informed consent, probably a hold harmless agreement. But our county legal department felt that even with a hold harmless agreement, that the potential for liability if the recording was released by a third party was significant enough to preclude us from using recorded eDOT on Skype for now. So we only use real-time Skype. And as always, we'll continue to consider other options for eDOT, but that's about as much as I can share with everyone regarding our use of Skype.
Excellent. Well, I think that's very helpful, and certainly it's a caution to all that there should be a legal opinion in your jurisdiction that weighs in on what the liabilities or ramifications for your program might be. Another question that came in, part of this was answered by Richard when he indicated that that in the research project that they're doing, there was an expansion of criteria to allow for children. But for the other programs that have presented here today, do you have any restrictions against children or different policies for children?
We actually have someone that has a baby on Skype right now. They use it as a form of, face-to-face and video because the dad has a lot of appointments because the baby's had a lot of medical issues. But we look at it just like, again, it's case-to-case, what works best. But for children or under 18, of course, the parent has to be there to administer the medication, just like they would on face-to-face DOT. That's the only one we have, I believe, that's under 18 at the time. So it is a case-by-case situation we would look at. But, again, in this instance, baby was very sick, has a lot of appointments. This works. It's in combination of the face-to-face and Skype.
Excellent. Thanks. Another question that came in has to do with monitoring for adverse effects. Any comments from our presenters on that question?
Well, in New York, we ask our patients at pre-observation and post-observation, we ask them were they experiencing any side effects. And as with my case study A, if the patient is reported that they're having side effects, we have the ability to either bring in a physician who's in the office here with us or a physician remotely, because the video conferencing software that we use does allow for multiple people to be on a video conference at one time. So we do ask at each session if the patient experienced any side effects from the previous observation, and at the end of the observation they are asked again, are they feeling okay after they've ingested the medication?
Excellent. Thank you, Christine. Any other comments from our presenters?
This is Patty again. With the side effects here, they have a DOT sheet, and there's a criteria of all the side effects you have to ask, whether they're face-to-face or whether they're doing it video DOT. So even if it's video DOT, they're still responsible for asking all those questions and taking the same appropriate steps that they would if they were face-to-face.
Excellent. Thank you. I'd like to thank all of you very much. Thanks to our faculty for sharing your knowledge and experience with all of us, and thanks to the participants for your questions, input, and discussion. I think it's been really a very interesting and useful webinar that we have been able to have here this afternoon. And finally, the New Jersey Medical School Global Tuberculosis Institute provides medical consultation services as well. You may call 1-800-4TB-DOCS with any questions requiring medical consultation in the Northeast, or if you're in another part of the country, you may call the Regional Training and Medical Consultation Center that provides services to your program. Thank you very much. This concludes the conference.